Welcome to the Impact of the Philips PAP Recall on Vulnerable Populations, a multi-society panel discussion hosted by the American Academy of Sleep Medicine. I'm Thomas Heffern, Senior Director of Marketing and Communications for the Academy. This discussion will be based on the information currently available from Philips as of June 25th. Limited information makes it difficult to provide clear answers to many of your questions, but our expert panelists will provide their best insight on how they are navigating this challenge. Your questions also are giving Philips a better understanding of the information that they still need to provide to the sleep medicine community. Questions that aren't answered during today's webinar can be submitted to the Academy by sending an email to recall@aasm.org. This webinar is being recorded, and the recording and a copy of the slides will be posted online for public viewing. Now I'd like to introduce our moderator, Dr. Shannon Sullivan, Chair of the Academy's Public Safety Committee. She's a clinical professor in the Stanford University School of Medicine. Welcome, Dr. Sullivan.
Thank you so much, Thomas, and to the Academy. Next slide. I am so grateful today to be joined by so many of my colleagues, and I just want to give a brief introduction. We have with us today Dr. Joshua Bendit. He's professor in the Division of Pulmonary Critical Care and Sleep Medicine, as well as a medical director of respiratory care services at the University of Washington Medical Center. We have Dr. Rakesh Batterjee. He's representing the American Academy of Sleep Medicine, and he's the director of pediatric sleep medicine at Rady Children's Hospital in San Diego, and an associate professor of pediatrics at UC San Diego. Welcome. We also have with us Dr. Michelle Cow, also representing the American Academy of Sleep Medicine. She's an adult pulmonologist and clinical associate professor in the Division of Neuromuscular Medicine and Division of Sleep Medicine at Stanford University. We have with us Dr. Michael Howell, representing the American Academy of Neurology. Dr. Howell is Vice Chair for Education in the Department of Neurology at the University of Minnesota and Medical Director for the M-Sleep Health Sleep Performance Training for Athletes. Welcome. We have Dr. Sherry Katz, representing the Pediatric Assembly of the Canadian Thoracic Society. She's the Director of the Sleep Laboratory at the Children's Hospital of Eastern Ontario and a clinical investigator in the Research Institute. We also have with us Dr. Jennifer Martin, representing the American Academy of Sleep Medicine. She's a clinical psychologist and professor of medicine at the David Geffen School of Medicine at UCLA, with a research program evaluating improved care for patients with sleep disorders, including sleep apnea and insomnia disorder. She is also a member of the AASM Board of Directors. Welcome. We have Dr. Jeremy Orr, representing the American Thoracic Society. He's a pulmonary and critical care physician scientist and the director of the UCSD Pulmonary Neuromuscular and Assisted Ventilation Program. And we have Dr. Lisa Wolf, representing the American Academy of Chest Physicians. She's a professor of medicine and pulmonary and critical care and neurology at Northwestern Feinberg School of Medicine. Welcome to all of my panelists, and thank you so much for being here today during this time. Next slide. So again, I think this is a story that's pretty familiar to us, but to provide a little bit of background, last week on June 14th, Philips initiated a voluntary recall notification in the United States for specific models of continuous positive airway pressure, including CPAP, bi-level, and mechanical ventilator devices, stating that the recall was to ensure patient safety and consultation with regulatory agencies. The recall was meant to identify potential health risks related to the polyester-based polyurethane sound abatement foam used in these devices. And foam degradation was cited to happen over time, a process that seemed to be accelerated by high heat and humidity, as well as the use of ozone-based cleaning systems. Next slide. Here's a pictorial view of some of the devices that are involved in the recall. As you can see, it's a wide spread of devices that Philips manufactures, including the A series in facility devices. Next slide. There are also some devices that are not affected, and this may come up in our conversation today, so I wanted to take a minute to point those out. And next slide. And this is just to remind again that the text of the notification or the recall notification actually indicates that for life-sustaining mechanical ventilator devices, Philips has a statement: do not stop or alter your prescribed therapy. This is to patients until you have talked to your physician, recognizing that in some cases where therapy disruption is unacceptable, at the discretion of the treating clinical team, the benefit of continued usage of ventilator devices may outweigh the risks. And I think we'll be talking a little bit about that today. However, that recall notification also states that for folks using bilevel and CPAP devices, that use is to be discontinued, and that patients should work with their physician or durable medical equipment company to determine the most appropriate options. Next slide. So with that brief backdrop, and again, I think we're all familiar with aspects of that at this point on the call. One of the questions that's come up, this is a conversation that's been ongoing, is around thinking about allocation of resources. And I want to point out for a minute that this is a question that we didn't get to address in the webinar we had 1 week ago, where we had a number of folks come together again across societies to really think about how to adjudicate the patient care in these circumstances. And through the leadership of a lot of folks on that call, including Dr. Peter Gay, we're really able to put together, and his colleagues at Mayo were able to put together sort of a framework across societies for how to address these things. But there are serious questions around allocation that we did not address. And so I was hoping that we could start the conversation today thinking about allocation in some of our most vulnerable patients. Those would be ventilator dependent patients and chronic respiratory failure, such as patients with neuromuscular disease. So I thought maybe to start off, we could ask you, Dr. Michelle Cow, to start thinking about, or help us understand some of your thinking about how to approach these populations.
Sure. Thanks, Shannon. So, when this all happened, I think a lot of my colleagues and I felt like we all got PTSD, right, from the days when COVID hit us, and we had to rationalize ventilators for certain patients and who can get them, who could not. So this kind of brought us back there again. We talked about this a little bit and how we approach this. And I think one of the things that we, I talked to my colleagues about, how their practices work and as well as mine. And I think, we decided to put together sort of a protocol or just a guideline for our colleagues to help us, guide management decisions. Can you go to the next slide?
Next slide, please. Thank you.
So I think one of the things I recommend, though, for providers who see neuromuscular patients or patients who deal with chronic respiratory failure patients, is that number one is you want to discuss with your your DME, local DME providers on their inventory, what devices they carry, the Philips and non-Philips ventilators, so that what sources are available for you, and work with your DME providers to help your patients. And so after that, I think that based on what Peter Gay did, and it was very helpful for many people. We thought that we put together this framework as well to help our providers, but this is not, as Shannon said, set in stone. But I think you need to really think about your patients and how dependent they are on the ventilators, right? So it's number one is dependency, and number two is how often are they using the ventilators? Are they using it 12 hours a day or less? Are they using it 24 hours a day? Your tracheostomy patients, as well as their disease process. So some patients have certain diseases like ALS, which is rapidly progressive. Other patients have a more chronic disease like, myopathy. So that also helps you make management decisions. So this is a guideline that we sort of put together. And you can see here quickly is that if you have patients on these devices and they meet the criteria of serious medical conditions, then you definitely don't want to stop treatment. And then after that, the filter is the first thing that we recommend. After that, I think it's really important that you know what your patients are doing. So that care orchestrator, being online with your patients and having that download report in the most recent 30 days would help you know if your patients are dependent on it, how often they're using it, and that can really help you decide if you want to change your ventilators. So for example, like if a patient's on a Trilogy and they're using it for at least 12 hours or more, then you're going to want to change that ventilator to a Philips Evo or a non-Philips device. If they're using it less than 10, 12 hours a day, then you want to consider a switch to a ResMed device, such as a bilevel PAP. And then we also have the category for patients on the RAD device as well. Again, if there are patients who are using a RAD device like a ResMed, like a Philips BiPAP, but they're actually using it, like 15 hours a day or longer. Those patients might qualify for a ventilator, and therefore you have the option of switching to a Philips Evo or a non-Philips ventilator. So these are just guidelines that we're thinking about.
Thank you so much, Michelle. I think this is great. And there's a question in the chat. Can the slides be enlarged? And I think, this is for the purposes of discussion, but you may be seeing some of this thinking posted later so that you can take a more careful look. I understand there's a lot of words on some of the slides you're going to see today, and hopefully our panelists can walk us through their thinking on it. Next slide. So, Michelle, one of the things you brought up is that, it's important to think about the overall, like where your patient is and what their overall disease mandate is, and thinking about whether or not there might be opportunities to switch to other devices. But of course, in the background of all of that are, can we go to the next slide? And next slide. So one of the things that comes up for me when you're talking about switching devices is whether or not switching to another device is feasible, because there just may not be enough devices to go around. And as you mentioned, this bears some similarities, or for those of us who've been managing sleep and pulmonary practices through the pandemic, especially early on, concerns about not having enough devices were there. So I was wondering, Dr. Howell, if you could walk us through sort of how your practice is thinking about, these concerns and how they relate to what we've just been through during the pandemic.
Thank you, Dr. Sullivan. I appreciate the question. It got me thinking about how, from my experience anyway, that COVID was a bit of a slow burn, and that we had kind of heard that this may be coming, and then is this really going to be as bad as it looks like? We had heard before June 14th that there were some problems with the sound insulating phone and some of the other Respironics devices, and I was a bit thought this was a problem, but didn't quite completely appreciate how large this was going to be. And then even when June 14th came, it took me, as well as many of my colleagues, a little while for this to really sink in terms of exactly how much of a mess this was going to be. One thing I would point out is just how wonderful the collegiality and the camaraderie has been. This has definitely reminded me about early in COVID. I mean, right now we have almost 700 people sleep. I mean, that must be a huge fraction of the overall sleep providers in North America, and just the need of recognizing a problem and needing to come together to kind of help solve it. We were talking a little bit before, Dr. Sullivan, on how similar or dissimilar this is for the when we got the SERVE-HF study results. I remember that morning waking up and thinking to myself that it's not possible that we're going to have to stop ASV on so many individuals. And I think the difference here is that, I mean, that was a situation where there was clear, unmistakable increase in mortality with using of ASV therapy. And here we are in a situation where I'm curious what the rest of the panelists say. More often than not, when I've had conversations with patients, I mean, the vast majority of the conversations I've had with patients over the last week has been stay on your treatment. These are especially the folks who have severe underlying disease. And then the whole nature of early COVID was just so fundamentally different, since we didn't have access to diagnostics. We weren't able to see patients literally. We couldn't see them in person, obviously, but we had to scramble to get video conferencing up and running. And now, of course, a year later, we're all Zoom is a verb as much as it is a noun. But curious, any of the other panelists' thoughts, or yours, Dr. Sullivan?
I'll leave that open to the panel. And also, while this is going on, thank you so much for those of you who are writing in on the Q&A and in the chat, because I think there's some good questions about this as well. Anyone else on the panel want to comment on Dr. Howell's thoughts?
Hi, this is Lisa Wolf. So what I wanted to say was that, Dr. Howell talked a lot about other sort of instances that we've been in, specifically looking at SERVE-HF and what it was like that day. And one of the things that I find also very similar is that in terms of SERVE-HF, the risks were still pretty low. And we made decisions on a patient-to-patient basis, knowing that our risks were low. And I would want to say, yeah, I feel like this is very similar to that. And so I think that we should all just bear that in mind.
Excellent point, Dr. Wolf.
Yep, no, I think that's exactly right. And someone has actually, so here's something just to open this up to everybody on the panel. Someone's written in and said, at your own institution, have you been working with legal or risk management at your institution, or has that been a piece of the picture for you all?
For us, no, not yet. Maybe we should, but not yet. That has not been a high priority.
We just used the Epic MyChart function to blast a letter to our families, and that went through risk legal management. Because we had to be very careful in how we word these letters, considering what's going to happen moving forward.
I think for the sleep labs who use exclusively Philips, the Omni Lab, I think that many are using consent letters, consent forms, just to make sure that they can still, keep their business going and titrate patients.
Yeah, anyone else want to share experience on that before we move on? That's a great question. Thank you. Thank you again for writing in on it. So if we could go back to our slides for a moment.
Shannon, there's a question in the chat about the foam and the ResMed machines. I will share that I spoke with them and they said they use a different foam that doesn't have the same concerns. This is verbal, but that's what they said.
Oh, thank you.
So
thank you so much for bringing that up. And you can actually navigate to their website. I think they now have a statement. I want to say since the 21st of June, they've had a statement in their FAQ, so you can navigate to their website. But that's exactly my understanding as well.
And Shannon and Jennifer, it's almost like a gel more than a foam, which is why you don't have to worry as much about the volatile gases, et cetera.
So it's a different technology altogether. Interesting.
So again, thinking about collegiality and thinking about like putting our heads together on how to sort of navigate these tough situations. Michelle shared some of her thinking, and Dr. Howell, they're thinking on sort of these like chronic respiratory failure patients you may be managing at home, but there's a whole different set of concerns with patients who might be going from home to the hospital. Because of course some hospital systems are affected as well. And then also some patients who are in the hospital and you're preparing to discharge them home. So I thought maybe we would start with from hospital to home. And I might, next slide, ask Dr. Orr to sort of hold forth a little bit on how he's thinking about things. And here's a slide that one of our panelists provided. But maybe Dr. Orr, you can walk us through your thinking and maybe some of the slide as well.
Yeah, thanks. And I appreciate being here. I think the big takeaway for me on this is that, these patients are not your average sleep apneic patients. These are patients who, even if they are not using a ventilator, even if they're not using Trilogy, they may be using a bi-level ST device. Those patients may be maybe not vent dependent, maybe that's not the right word, but they will decompensate, at some rate. And, for a lot of our patients, we don't know exactly how fast that's going to happen. I mean, we might have some sense based on, lung function testing and prior experience. But, I really think it's not about the device as much as it is about the patient, their diagnosis, and sort of your perception of what their risk is. So I just wanted to make that point. And I think the initial recall notice was a little bit conflicted on that. It was a little misleading in that it seemed to imply it was about the device. If the patient's on a mechanical ventilator, those are the people you need to be worried about. But I just wanted to emphasize that I think that's not really the right way to think about it. And so this goes into what we're doing with our patients if they end up in the hospital as well. And really the high risk categories, and we don't have COPD on here, but basically, I think it comes down to neuromuscular disease, severe obesity hypoventilation patients who are requiring bi-level support, and then, COPD patients who are also requiring bi-level even with or without a backup rate, frankly. So it doesn't matter the device. And for those patients, I think really our goal is to continue some therapy while they're in the hospital. And this is not patients that are ending up in the ICU, obviously intubated or something like that, but these are patients who are going to be continued on, non-invasive therapy. So what we're trying to do at UCSD is, transition people to a hospital device that's not, one of the recalled devices. If that's possible. And if you want to do that, you can't just pick generic settings. We spend a lot of time titrating these patients. You can't just put them on, 10 and 5 and hope that everything's going to be fine. And again, what that comes down to is having that remote monitoring data, being able to look back and see what they're on, having, good documentation in your notes. And that's a challenge. It's taken us a long time to get up to speed on that. And I don't think everybody has that, but what you want to do is transition somebody if you are confident that when you move them onto a different device, that they're going to be getting the right level of support. If they are, needing to stay on their device for one reason or another, we think that that's fine. We think it's a risk-benefit decision, and what we should be doing is trying to, minimize the risks. And one way that seems to be, appropriate to do that is to use a filter. If the patient hasn't already received one. And so, we know these filters are useful in terms of particulates and not so much for volatile organic compounds. But they're probably better than nothing. And so, I think we should be including that in sort of our protocols. Yeah. Oh, Lisa, please.
Jeremy, I just wanted to throw in just 2 things about filters, because there's been a bunch of questions in the chat in the question box. Yes, these filters can clog, but the answer isn't to stop using them. It's to change them more frequently. And especially the HEPA filters should probably have daily on inpatient and weekly on outpatient switches. And then the other thing is the presence of that filter, especially a HEPA filter, may change the ability of the circuit to understand triggering. So if you're going to change and add to your circuit a filter, make sure that you adjust your trigger until your patient is feeling comfortable with ventilation. Sorry about that. I just wanted to throw that in.
Those are great comments. And I think, especially for your severe neuromuscular patients or severe COPD patients where triggering may be a real problem, any small change in the circuit can really affect things. And so, we need to be thinking about that. And that also goes for, if you're transitioning a patient to a hospital device, we need to understand that some of these patients are very, very high risk and very fragile. And anything that we do needs to be weighing those risks and benefits and as much as possible, minimizing the risk to the patient. So as far as transition to home, again, I think we'd follow the general guidelines if this is a patient who is already using non-invasive ventilation, as far as the approach to take upon their discharge home. But for new starts, again, this becomes a little bit of a concern about supply. And I think we're going to get into that a little bit later. So as much as you can leverage knowledge of your DME companies, local ALS and MDA programs, to understand what the availability is out there. You want to anticipate that and try to evaluate that early in the hospital stay. And then I guess the last point might be for neuromuscular disease patients who sometimes have 2 mechanical ventilators. Really, we should only be giving 2 devices to patients who really need it. But my experience has been that sometimes people accrue, 2 ventilators, one as a backup. And, we really shouldn't be, we should use this as a time to sort of not be doing that, using 2 devices only in patients who truly need one.
Thank you so much for that, Dr. Oren. Next slide, please. So it's interesting because there's 2 different levels of complexity there. There's, again, just as you pointed out, there's folks hospitalized that you're preparing for discharge and for home. And then there's also folks who are at home who might be in a pretty fragile state that you need to transition to the hospital. And I think, thank you also, Dr. Wolf, for commenting on filters. You're right. There's a lot of comments, there's been a lot of conversation about this outside of this webinar and continued questions in the chat. I think, have anybody on the panel, on this panel experienced shortages of the filters themselves, that it's been hard to get? And any other commentary on that?
And I have not. I mean, I think that the DME companies I work with locally, they're respiratory companies, so very aware of what's happening. They are triaging the most needed patients first, the tracheostomy patients on 24/7 ventilator support, and they're giving extra filters temporarily while they deal with the inventory and what they can provide or not. But they're definitely telling their patients to change the filters probably every week instead of once a month. And like Lisa said, that it depends on what you're doing. But I just want to make a point with the filters is that if you're using a RAD device like the ST devices or AVAPS devices, or the filters can be used with those devices. You just can't use the integrated humidifier. So if your patient can handle using the device without the humidifier, then that is an okay option temporarily.
Right, I think that's a great point.
I just wanted to clarify, they can use the humidifier, but they can't use the heated wire circuit, because in order for the heated wire circuit to work, it has to be plugged in to the same area where the filter goes. So they can still use the water, they can still use the tank. The tank itself can be heated. You just won't have the circuit going. The risk there is that you can get rain out because there's nothing preventing the temperature change in the circuit. And this is going to show how old I am. Before we had heated wire, like the olden days.
You're not that old. I remember those days when we had rain out all the time.
Yeah. So just things that you can do is get tubing wraps that are officially made. You can just have crafty people go to like Michael's and get a remnant of fleece and use that. You can use pantyhose that have run and cut the toes off and put those on. And so those are the kinds of techniques you'd have to go back to.
And Dr. Martin.
I just want to respond to something that came up in the chat, which is actually a really important issue. The fact that a lot of payers, Medicare notwithstanding, or including Medicare, require adherence thresholds in order for people to keep their device. So the AASM did send a letter about that to some DME MACs and private payers, which is posted on the website, but that's definitely on our radar because we wouldn't want to penalize patients and create some longer term problems because patients followed the instructions on the manufacturer website. So thanks for that question. I just wanted to let folks know it's definitely something we have in mind.
I think that's
Jennifer, I wanted to also say with that one is that for the RADS devices, it does go into that 90-day compliance policy, unfortunately, but for the ventilators, that it doesn't go into that policy.
Right, excellent point. Yeah, and I hope we get a little bit more into what it means to suddenly to follow instructions when we start talking about research participants and things, because I think this is a really interesting question. Let's go back. There are a couple really important points I wanted, again, that are in our slides that some panelists provided. Let's go back to this question of hospital admission. Dr. Wolf, do you want to take this one?
And just to shorten it to the take-home points here, for patients that are on devices and transitioning to the hospital, if you're at a hospital that currently will only let people use hospital devices, you may consider letting them use their own devices, especially if your hospital doesn't have a sufficient number of approved devices. Number two is that in patients that are on their chronic equipment, again, if you're using filters, you have to adjust your trigger. And also, and this was in the chat, consider getting old devices out of mothballs like the LTV ventilators, transport ventilators, and even MRI ventilators. And for those that were asking about the LTVs, they are still great working vents. You're right, we used a ton of them in COVID. The only problem is that the circuits are proprietary. And so what we've been telling the home patients is to try and use the circuit as long as possible because the circuit may be the limiting step on that. Shannon, you're off, Shannon.
I saw that. I heard that. Any other panelists want to comment on some of these considerations? I did want to. These or some of the comments we're getting through on the chat around filters. Perhaps we're being confusing too, because On the Philips website, filters are mentioned for use with ventilator devices, but not with CPAP and bilevel. And so we have some folks writing in. Does anyone want to take on that? And this is a continuation of a discussion from last week as well. Anyone want to take that on and share how they're navigating that?
I'm so sorry. Just one thing real quick is that the use of the filters is something that we're talking about as our personal experience. I just need to just say up here, it's not a recommendation from the American College of Chest Physicians, because they told me specifically to say, make sure that we distinguish that. And in terms of the availability of filters, there's been some stuff in the chat about increasing price, et cetera. During COVID, there was a huge rush on filters, and we have had trouble getting our stocks back up to par since then. I will tell you, the only reason that we have filters right now is because what we requested a year ago finally just came in. So I think it'll be interesting to hear what other people's perspectives are on that.
And this is Josh Bendit.
Yeah.
One thing I think we need to make super clear is that the filters are just for particulates. They have no effect on the volatile organic compounds, which in my opinion are probably the more risky, over time. So I think that needs to be borne in mind as people are talking with their patients.
Well, that's a perfect segue, Dr. Bendit. Thank you so much. Let's take a look at the next question. If we could go to slide number 14, go forward one, please, and talk a little bit. Go forward one more slide. We've been talking a little bit about these patients. There you go. So Dr. Bendit, navigating this as the head of a respiratory therapy unit in a hospital I'm sure these questions are coming up. And I was wondering if you could talk a little bit about navigating hospital needs with the recall of the V series or A series, depending on where you are, the facility-based devices.
Sure. Thank you. This is an ongoing discussion, and we have a 4-hospital system at the University of Washington, and we're meeting as a group to try to get this, evenly managed across all the institutions. And we are having our legal department do this, because these are things. So let's say a patient comes in, they've not been on non-invasive ventilation or a ventilator before. What should we be using? And I think in the next slide, Lisa Wolf very nicely put this together. And the one thing that at her institution is a big issue, they have many V30s, which are on the recall list. We have just a few of those. We have V60s as the major unit that we use in the hospital, and they are not on the recall list. And we are looking at alternatives. So if you look at the alternatives underneath the V30, the V60, the Trilogy 202 for people who happen to have the Briaz device, and then their ResMed devices. And also some of our ventilators can do non-invasive ventilation. So we use Servo-Eyes, they can do non-invasive. So we are using alternatives. And I think this is where legal issues come in, because if you're prescribing a device which has an issue, I think that puts us a little bit more at risk. And we are certainly getting opinions from our legal group. So this is an ongoing issue. We're using ones that are alternatives. We're trying to avoid using ones that have definitely been on that recall list, starting in the hospital. Now, if patients are already on them, as we've discussed, it's totally reasonable to say, bring your own device. We inform you about the risks. And for my patients, for instance, the risk of dying off the device far exceeds, even any suggested risk down the line, especially if it's just for a short period of time. So I'm talking about prescribing in the hospital. That's kind of how we're doing it. And I'll leave it to the other panelists to comment how they might be approaching that.
Oh, thank you so much. I think, those are some, that's some innovative thinking, again, in a time when we just don't have enough resources to allocate. I think those are some pragmatic types of solutions. I'd like to switch gears a little bit. There's a couple panelists we haven't heard from yet. Next slide. And I would like to talk a little bit about, we've been talking a lot about, patients in fragile situations in terms of where they are in their ventilatory status and moving in and out of the hospital. But, really a unique group of patients here is pediatrics. I think there's a number of unique issues facing those of us who are pediatric providers in this space. And I'd like to hear a little bit about how, to talk a little bit about approaches that can be adjusted to take into some of these special pediatric facing issues. So Dr. Batterjee, would you like to lead off that discussion?
Yeah, thanks, Dr. Sullivan. So if I get the next slide, I think what inspired us in terms of getting involved in this is there was a lot of crickets heard in the last meeting, and that's not to take away from the panelists, but we're somewhat of an underdog in this arena, but we don't think we are. We actually just published to the Medics Cloud that there's about on 21,000 kids who are using these devices. So there is a large population of children using devices, not only nationally, but across the world. So I think there's going to be a lot of impact. And so Maida, Chen, and I sort of had a call over the weekend, and we thought, let's put our friends together, including Dr. Katz, who you'll hear from, in terms of trying to navigate how we can help the kids with making this decision. And I think one thing that was very apparent is that we can make our recommendations, but we have to be very cognizant of the family and the child. And this is really a joint decision. And when we make this decision, and we were thinking of formulating a flow chart very similar to Dr. Gay's flow chart from last week, it's really an orchestra of different factors that come into play. Of course, adherence is going to be an important factor in terms of whether kids are wearing it, whether insurance is going to approve it or deny it. But I think, with children, there's a lot of variability in the nature of the disease that we have to sort of account for. We also have to account for that children, the risks regarding the sound abatement form, we just don't really know. We don't know what nothing's been stated about children. Children have lower lung capacities, and so how much of an impact it has on the developing lung is of concern. The children are also developing, so how much of this is going to result in long-term sequelae is really unknown. So there's a little bit of nervousness across us as pediatricians. And I think what makes it more complex is we have to also account for the fact that there's these disease thresholds that we use, like we all use, like the AHI and the oxygen saturation, and we also monitor carbon dioxide. But there's also this understanding that that does not necessarily correlate perfectly with the severity of disease. So some children who might have what we call mild OSA may actually have much more symptoms, and somebody with more severe OSA may not have a lot of symptoms. So how do we really navigate through that? The other factor in this decision is that in many cases, these devices, like BiLevel, and I think Dr. Orr was mentioning this before, but are used as life-supporting or life-sustaining measures, particularly in our neuromuscular patient population. So these children are equally affected in those regards. So taking it all together, we have different issues. And then the last thing that sort of was a discussion that we all sort of thought about is, there's a lot of variation, not only statewide, but internationally with regards to how these devices are regulated. The FDA, for example, doesn't approve a lot of these devices for kids under 30 kilograms. And so we need to factor that in, that there's variation. And so when we're now actually to the stage where we're going to share these documents with our colleagues around the world, where we need to sort of factor how that matters. And when you think about the availability of alternative devices and treatment, like other ventilators, there is a lot of variation. I mean, how do we know what's going to happen in Canada, which I think Dr. Katz will talk about, but even in Europe, even in Africa, do they have a lot of these alternative devices readily available for them. So it's going to be challenging. And I think this is really an opportunity for us to kind of come together and try to put it all together and help our colleagues.
Thank you so much for that. And I think so many salient points. And Dr. Katz, would you like to provide a little more color for us on the issues you're facing with your population?
Sure. I think a lot of the issues really pertain to everyone around the world, that we're all struggling to try and figure out the best approach for our patients and balancing risks and benefits and looking at what alternatives are available. The guidance in Canada has been a little bit slower to come because information from Philips about how this is going to be handled in Health Canada has been a little bit slower as well. But I think we're all in the same vein of trying to figure out the risk benefit and inform our patients to the best of our ability what the best clinical decision for them at this time is going to be. I wonder if you might want to advance the slide, because in the group that Dr. Bhattacharjee has led, we've had a lot of these discussions, and I think regardless of where you are around the world, the pediatric group have some fairly unique considerations in terms of what the long-term effects are going to be, what options are available for switching ventilators, and may be different. Availability of those may range around the world, but there may be fewer options to switch kids. And many of our patients have a great degree of underlying comorbidity and medical fragility that makes it such that the option of stopping ventilation really isn't compatible with managing their medical conditions. So certainly for children who have neuromuscular disorders with hypoventilation, those with central sleep apnea or hypoventilation disorders of other types, those with chronic lung disease and chronic respiratory failure, the cardiovascular disease group, and those with pulmonary hypertension, and those with severe upper airway obstruction with gas abnormalities, there really isn't much of an option but to continue with their current treatment until their device is replaced or repaired. And while there is certainly the need to have a discussion about alternative options with the child and the family, in many cases, there may not be a palatable option other than to continue their non-invasive ventilation. The other group are those who have significant daytime dysfunction related to untreated sleep disordered breathing. And while the considerations here may not be the exact same as for adults, unless you're a teenager who's driving long distances, which is rare, there's a significant impact on school, family functioning, and family unit functioning by stopping these devices. So here too, there's an ability for shared decision-making to take place between the families and the practitioners. But for those who have significant impairment of their daytime function, the best option may well be to continue with their current treatment. For those who are perhaps less symptomatic, or those who have sleep disordered breathing that may be amenable to other treatment options. So in young children, a surgical option may be something to be considered. There may be different discussions to be had. And in those individuals, there may be a subset of them in whom it might be appropriate to stop therapy temporarily until another device becomes available.
Thank you so much, Dr. Katz. And I really, I appreciate, so, you know, what's nice is that this, in a way, follows the format of some of the thinking that Dr. Gay presented last week, and that a number of the panelists worked on. And again, that can be found by linking to the AASM website. But there are some really unique features here that I wanted to call out. I think, just as you said, I think the family is a unit, and how dysfunctional breathing and ventilatory needs are for the child affect the entire family is something that really has to be taken into consideration. And that this is not necessarily it doesn't fit well into the mold of it's an AHI driven decision, because the impacts for children can be much more varied and affect a lot of domains that just don't get well captured in that particular metric. So thank you so much for providing a little bit of context for us. Any other panelists want to comment, who might be working with children, want to comment in this space before we start considering another vulnerable group, our research participants? So let's move on then to Dr. Martin. And next slide. and any of these, as you know, we could talk about all of these topics for at least an hour or more. But I want to make sure that we have a chance to really talk about another very special vulnerable population. Those are people who agree of their own accord to participate in research trials. Because they, we have a very special relationship with our research participants, and really sorting out how to ethically navigate the recall for those who are enrolled in clinical trials is a really important question that we haven't had the chance yet to discuss in a webinar like this. And I was hoping that we could have some discussion right now with Dr. Martin and the entire panel group.
Yeah, thanks. So as you mentioned in the introduction, I'm a clinical psychologist, so who knew that my life would become about a CPAP recall? But, one of the challenges that's come up for those of us doing clinical trials using CPAP is obviously the issue of safety. And one of the challenges here is that this is a recall notice that probably doesn't appreciably change the risk-benefit ratio of participation in a trial. Most of the studies that are going on now are not in asymptomatic patients. They're in patients who are high risk for complications or have other significant health issues. I mean, I feel like the easy studies are done now. And so, that's been a challenge. I think one of the shortcomings of the information that's out there for us right now is that we don't have a lot of good resources to provide to participants, to human subjects committees, to data safety monitoring boards to inform what the best course of action is at this point. I feel like I was lucky enough to get some good advice locally about the fact that while this technically doesn't qualify as an adverse event or an unanticipated problem, if you read the common definitions, it is potentially something that would impact a person's willingness to participate in a clinical trial. And in those instances, investigators are typically allowed to contact subjects and provide them with information, written or verbally, without first getting human subjects approval. So you can usually do it first and then notify the Human Subjects Committee or your DSMB after the fact. So that's been very useful, because one of the challenges that I think a lot of us have is that getting anything approved doesn't happen quickly. And, I think there is, maybe this brings me to one of my third points, which is trust. And we know that there are significant challenges, especially in racial and ethnic minority communities. And I do a lot of research with women who are military veterans. There are a lot of trust considerations. And I think not communicating quickly to research participants about this has some ethical concerns as well. I think that's another consideration. So I think the last thing that I'll say about it is that, we have erred on the side of being transparent and providing a lot of information, and then using the infrastructure in the study to help patients get their devices registered. Because we're working with patients that have comorbid conditions or high risk, we've decided not to universally tell them to stop using their equipment, their treatment, but instead to help them get registered for the recall and offer to have one-on-one conversations with them about their perceived risk benefit, and then supporting them in the decisions that they make. We are having some challenges trying to figure out analytically, what are we going to do when we're looking at clinical outcomes where using the device is really important? So if we're trying to reduce hypertension, for example, and we have a period during the follow-up interval where patients stop using it because of the recall, how are we going to account for that analytically? I don't have an answer for that yet, but I think given what came out in the AHRQ report, a lot of us are concerned about, the 10-year ramifications of underpowered clinical trials or failing to detect an effect because there's a 6-month period where people who are adherent are actually not using their device. So I think there are, as you mentioned, Shannon, some unique issues because people have trusted us and enrolled in something that is by definition experimental, and really trying to honor the voluntary nature of research and think through the scientific implications of this over the long run. I think we are probably in our own program going to switch devices, which presents its own set of analytic problems. And I think for people who are doing longitudinal studies, it's a bigger issue than people doing randomized controlled trials. If anybody has any questions or if I can be helpful to any of the researchers on the call, I'm happy to talk offline too.
Well, I think you brought up so many important issues. One of them is this issue of trust, because I think that's something that we all share in the care of all of the different venues in what we're doing. And how do we communicate well with our patients? Someone brought that up earlier too. How do we broadly communicate? How do we help people get their devices registered, which of course is, something that Philips has asked to do, and I think is important. And how do we maintain that level of trust so that we can continue to deliver for our patients?
Some of the very good advice I got is, even in research studies, we use shared decision-making. And I see there's a question about, what do you do about patients who are supposed to use PAP to get a medication, or to keep a commercial license, right? And like I said, the approach we're kind of taking is to have these one-on-one conversations with the patient and talk about the consequences of continuing and the consequences of not. Another thing that has come up for us is, for patients who are in a trial but are not currently using treatment, we are not encouraging them to start. So, if they're not using it right now, it's kind of like the addition subtraction problem, which obviously happens clinically, but we have decided that we're going to notify all patients who've ever been given a device as part of the trial, but to tell them if they're not using it, now is not the time to start either. That they should register for the recall and then, go from there. So.
Yeah, it's interesting. That's more pragmatic solutioning, like we've been hearing from a lot of the panelists. We have imperfect information, we have imperfect supply and allocation. So let's get down to coming up with some just really pragmatic solutioning around things. Any other feedback or last words in our last minute? Dr. Katz? Sorry, I thought I saw a hand raised. It came down again.
Dr. Sullivan, that was me. I guess my only tool that I would advise us not to forget are our colleagues in dental sleep medicine. Oral appliances can be really useful, and they can a good sleep dentist can develop a temporary device pretty quickly. Obviously, I think it's you got to make sure that they're going to a good dentist, preferably one board certified by the Board of Dental Sleep Medicine, but especially in that mild to moderate OSA range, where we may be really tempted to suggest they stop using the device for a while.
Could I bring up a really good question that came up on the panel? What others are talking about is what to do with their OmniLab equipment in their lab. Are you guys pulling out the foam? How are you getting reps changing it? Are you guys using consent forms? I think there's a lot of issues with the titrations, including in pediatrics. So just to see what others have done here in terms of dealing with the titration studies.
Rakesh, it's crickets again. I
guess I have that effect on everybody that I need.
We don't have OmniLabs.
This is Lisa Wolf. We actually don't have OmniLabs in our labs. However, I was speaking to some of the guys at the ResMed office this week, and they have paused on putting out the ResMed devices as well to try and make sure that resource allocation is adequate. And so the first thing I would say is that if you have an OmniLab, and you need to switch, register it with ResMed now, because it's probably going to take you a long time to get a device.
Okay, that's great, Lisa. Because the other thing for kids is a lot of them wait a long time to get their titration study. And so these parents, it's really hard to cancel on them saying that we don't have new equipment. So, I wonder if we as a community in pediatrics can try to jump the line like the vaccines.
Yeah. Dr. Katz.
I wonder if I could just comment not about the titration in the labs, but I'm just noticing in the chat that there seemed to be some discussion about who gets priority for different devices and how to prioritize people to be switched. And I think this is going to be a question that we're all going to struggle with, because there's certainly likely to be greater demand for these devices than supply. I think in Canada, we're somewhat fortunate in some ways in that in many provinces, there are centrally or central ventilator equipment pools, where there's one place that patients go to get their ventilators, and it may be easier to develop a framework for fair or prioritized allocation for patients that are highest risk. But I suspect going forward that broadly, it may be helpful to develop such a framework to help guide where the devices should go, should there not be enough to go around.
Such a great point. And as you know, in the US, there's not a single supplier. And in fact, it falls probably to us coming from our different walks of life and different societies to kind of come together and figure out a framework that can make sense. So that we really are addressing the needs for as many patients as possible in sort of a triage kind of fashion. So I think that's an excellent point. Other parting thoughts? Well, as that is the case, I'm going to say my sincerest thank you to each and every one of our panelists today for taking time out of your busy practices to share your experience and your ideas with all of us. This has been a fabulous session. And much as Peter Gay said last week, I think this is really important for us to continue to communicate and really sort of launch an effort across our different walks, across our different societies to try to help navigate this recall for the benefit of our patients and research participants. So thank you all.
This concludes the Impact of the Philips PAP Recall on Vulnerable Populations webinar. Additional information is available at aasm.org, and questions can be sent to recall@aasm.org. We thank our panelists for participating and thank you for attending.